Record. Okay. Hi again, everyone.
Hello there. Happy Sunday.
Happy
Uh,
Sunday.
might not be
Yes,
Sunday
because
when you're watching, of course.
right, exactly. Depends what day you're
Right.
watching. But now the nice thing about doing a Zoom is that I post it the same day that we record it, as
Great.
opposed to in the past we would record it and then it would be posted sometime later on in the future. But now we post it the same day, so it is a
Yep.
Sunday, and it's a beautiful Sunday here in
Yep.
Seattle.
Yep. And it's
Um,
good to see you're posting some of the old Patreons coming up there. I
Yes,
saw.
yeah, and
That's
and
good.
uh and I'm having some problems with it, as you know, because you brought it up to me. I can't seem to figure out how to keep the comments on when I'm uploading old Patreon videos. So if anyone out there has noticed that they can't comment on some of those videos, it's because they were old ones from Patreon, and for some reason YouTube just automatically closes the comments, and I don't know why. But we'll figure it out in the meantime. The other thing I want to point out is that people are still actually subscribing to our Patreon. I've refunded about 8 different people in the past 2 weeks or so. And while we greatly appreciate that, and obviously, what we do it certainly seems to resonate with people and people want to subscribe, and we love that. We are now on YouTube, which is free. So you no longer have to pay for a subscription on Patreon. We do recommend signing up for the free subscription, so you don't have to pay. There's an option for it to be free because we still will communicate on Patreon, and we will be doing some of our lives there because that's really the only place you can truly do a live as far as I understand it. So anyway, so definitely sign up on Patreon, but don't pay for it. And I will continue to be on the lookout and continue to refund if people don't understand and seem to
Right.
check the wrong box maybe, but you don't need
Uh,
to pay for the subscription any
And,
longer. We are free
and
on YouTube.
since we're doing housekeeping, conversely, please try to tell your friends and family and doctors and anyone about the channel so we can get increased subscriptions. Uh, I don't really understand YouTube very well, but I gather that the more subscriptions and the more views, the greater the chance that the site is discovered by other people. And that's what this is all about. That's why
Absolutely.
we made this change.
Right. Yes, exactly. Because we want more subscribers, because we want to spread the word
Right.
more.
So we need your help.
Yes, we need your help. We appreciate your help and we
Right.
appreciate your support for sure. And as you know, Dr. Kaufman is now on Blue Sky.
I
So
still have done no posting or whatever it's
I know,
called.
but you should. You should
I
get
know.
involved on Blue
But,
Sky.
I know we have a whole topic we discussed. Let's
Yeah.
talk about this. I suddenly realized the other day, often when I make my greatest eureka moments, frankly, it's when I'm taking a shower and thinking. And I realized my problem here is I'm used to communicating directly with people. Like if I want to talk to you or email, I text or email or call.
Right.
It just hit me. This is going to sound so stupid. It hit me that Blue Sky, Twitter, all those things, you don't actually talk to anyone. You just post and it goes out into the air, and people who are following you or whatever see it and might respond. I'm not talking to somebody, and I
Right.
haven't been able to wrap my head around it.
But you've got a lot of stuff to say, important
I
stuff to say.
know, I
So you
know.
just
So
sort of
I'm
put
going
it
to
out
try.
there in the ethos,
Right,
and
I'm going to
so
try. And one of the things I'd like to use it for is, as you do, I read constantly. I mean, it's never ending. And I'll read something, say, oh my God, this is great. I have to let somebody know about it. So I'm going to just start posting some of that stuff.
good. That would be great, actually, and I'll respond.
Good.
I'll
Good.
be
And I won't be alone and I won't
you
feel
won't
really
be
nuts. Okay.
I'll share it. I'll repost it. I will comment on it. I will
Good.
be your biggest fan.
All right. Get
All
to
right. So our topic for today,
it.
which David came up with this title, which I love, is eye rolling symptoms,
Right.
which by the way should
Right.
include eye rolling. But
Right.
uh, and these are symptoms, he and I, we always talk about how patients tell us stories of, symptoms that they think are odd. They're almost embarrassed to tell you. They're not even sure if it's a real thing. And sometimes when I ask a question, and I know this happens to you as well, David, like, do you have this particular symptom? The patient will say, yes, how did you know? And they're sort
Right.
of shocked that I had heard of it before or that it existed or that it was real. And so we recognize that that's probably a part of why so many patients are not taken seriously when they go to see other doctors or they show up in an ER or even amongst family members and friends, because
Right.
it sounds so odd. And it's like, really? Is that really happening? And
Right.
yes, it really is happening. And
So,
so we thought we would just sort of cover some of those symptoms
right.
today.
So let's start by defining our eye rolling. Okay.
Okay.
I assume that's a term that's used elsewhere in the world in other professions, but in medicine, where it's used all the time, Eye rolling is patient says XYZ, doctor doesn't comment yet, rolls their eyes, which is basically saying, oh, come on, give me a break. There is no such thing. You can't possibly have those nine symptoms. You're out of your fill it in mind, you know?
Right.
And eye rolling is the story of the ME/CFS and
Hmm.
long COVID. It's changing. Finally, there is clear movement, especially with long COVID, and it's great that all these papers are coming out, both journal papers, peer-reviewed papers, and New York Times and Time Magazine, all that stuff, clearly equating long COVID and ME/CFS. So I think eye rolling on the general illness will decrease a little bit, but the symptoms we're going to go into, are major eye roll drivers.
Yes, yes, for sure. Because they sound so unrealistic, I
Right.
think, to those around patients. And as like I said, it's not necessarily always doctors, but even to doctors who don't do the work we do, it doesn't make sense to them. They can't localize it, as I love to say that neurologists love to do. It doesn't, where would that localize? It doesn't, why would
Right.
that happen? And so I think it's important for patients to recognize that you're not crazy.
Yeah.
These really, we see these, we hear about these, we try to understand them, and these symptoms really do exist.
Yeah. Let's amplify what you're saying for a minute, because I think it's an important concept and thing to understand that we've talked about before. In school, medical school, and in training, we are taught to think in terms of organ systems. You learn about the heart, you learn about the lungs, you learn about the brain, you learn about part of the GI tract, you learn about another part, you learn about the liver, the spleen. You don't learn about head to toe. Okay. I mean, in effect, you're supposed to by learning all these systems. So doctors are trained to think in terms of the systems. Then they get into postgraduate training, which is internship and residency, and they're working 20 hours a day. They're exhausted. There's no way they're going to connect the systems in a way that we're talking about. And so when a patient comes in, whether it's to the ER, to the inpatient unit, or their clinic, and by the way, all their work is usually in the hospital, not in the clinic, which reinforces the whole system idea. And a patient says, I have headaches, chills, a rash, and every time I eat this, my heart rate speeds up and I feel brain foggy and my left hand is kind of twitching. The doctor rolls his eyes or her eyes and just says, all right, I don't know what I'm going to do, but how do I get this person out of here fast? So I think it's important for patients, people to realize that they're going to be speaking to a person who still is stuck in the silo organ system world. And
Mhm.
yes, functional med doctors are supposed to be doing it the other way, and I think many of them do, but it hasn't crossed over as much as we'd like to see it in mainstream medicine. So when you
Right.
tell your story, recognize who your listener is and what perspective they're bringing to it. It might make it better. It might make it easier for you to be heard, is what I'm trying to say.
Right. And importantly, know that your symptoms are real.
Right.
And so that, that is something that you can sort of stick your heels in. And you may not be in front, and we've said this before, you may not be in front of the right doctor. And then truthfully, the only answer is go find the right doctor. Don't waste your time. But know your symptoms are real. And if they're not willing to sort of entertain like what may be going on or how this fits into the larger puzzle, then again, go find a doctor who will, because it's your time and it's your health and it's your life and it's your prerogative, frankly. So
Right. Right.
I think that's important, but for sure, these symptoms are real. And so let's start with what some eye rolling symptoms are. I mean, I guess the obvious one is the eye rolling. So sometimes, there's something called opsoclonus in neurology, and it's sort of this like wayward eye movements that are, very, they're not rhythmic and they're sort of, there's no specific trajectory. It's not like nystagmus or it's just sort of where the eyes just sort of bounce around everywhere. And I wouldn't say that that's exactly what's described when patients report odd eye movements, but they definitely report odd eye. They feel like their eyes are shaking is often what I hear. And so, again, it's not an opsoclonus picture because sometimes I've had them send me picture or videos and it looks differently, but there
Right.
is some shakiness of the eyes for sure. It's like an eyeball kind of flutter and they feel it and they say that
Right.
their visual fields bounce. And so that is definitely a real symptom. And even though some doctors might eye roll at them, no pun
But
intended.
at least for that symptom, physician who's listening and is mildly thoughtful can look and they might see it.
Right. No,
Okay.
that's true. That could be visual,
Right.
but it's
So,
not present consistently, right?
right.
So, which is why I actually have rarely seen it in clinic, what they're describing to me, which is why I asked them to send me videos.
So
And they're really
another,
good at
I'm
that.
sorry, go ahead, Eileen. I'm
No,
sorry.
no, I just said just finished my sentence.
I'm
I said
sorry.
that patients are really good at sending me videos when I ask them to send me
Right.
videos.
So
Yeah.
since we're on the eyes, let's talk about one that you can't see, meaning I can't see it when you complain to me, but I hear it often is visual snow,
Oh yeah,
right? And
very common.
patients will say visual snow, or they'll say it's like the television when there's no signal and you just see
Yeah, the
the sort of
static.
stuff on the thing. And you can just imagine a physician who's got 10 minutes to see you hears this and there's like, what are you talking about? Okay. But it is a very real symptom.
Mhm.
Um, and I think, I mean, I don't know that we should try to associate a diagnosis with each symptom, but it's a symptom I hear in mast cell patients,
Mhm.
in uh, believe it or not, patients with Bartonella, and I think also brainstem compression
Yeah,
CCI
for
patients.
sure. So I think visual snow is actually, I agree with you. It's certainly one of the eyeballing symptoms. And, in neurology, we just talk about how it's notoriously difficult to treat and that nobody really knows what to make of it. But I think it's an electrical aberration of the retina, which is electrical in nature. It's part of the brain. And I always talk about the electrical nature of the body. Communication mainly is electrical, right? So action potentials, seizures are electrical aberrations. We even think migraines might be electrical aberrations. We're very electrical, which is why I think some people are so sensitive to things like EMF, which we're going to get to in terms of another eye-rolling symptom in that regard. But I also think that visual snow is just sort of this abnormal like depolarization of the retinal cells. And so which is why I think sometimes some of the anti-seizure medications at least don't resolve it, but take the edge off of it sometimes and can improve it. So I think that's what it's about. And the more we understand the body in terms of its ability to communicate, the cells to communicate amongst one another, which is usually electrical in nature. Obviously, there are voltage gated channels, right? So we can talk about electrical nature of the human body in another episode, I suppose. But I think that's what visual snow is, and so it's a real symptom. Lots of people report it. And I agree with you. I think it seems to be much more prevalent in those with significant mast cell activation in these chronic illnesses, and brainstem compression with CCI. We see it
Right.
all the time.
Which are, of course, related to each other.
Right. Absolutely.
Okay.
Absolutely.
Right.
And then there's visual disturbances of all kinds, right? So we hear all kinds of, in fact, I actually remember in residency, I learned that tunnel vision was psychiatric. So if a patient reports loss of peripheral vision, then it was psychiatric. That's what I had learned. Central vision is like an emergency, right? Central visual loss is an emergency, but peripheral visual loss is psychiatric. So, I've obviously since learned that that was not true. And I think that there's lots of visual disturbances that are described to us. And so some patients report they can't look at a white wall because it actually sort of sets off other kinds of neuro symptoms like they feel within their brain is how they describe it. But just by looking at a white wall, sometimes they'll report like flashing of lights, which I still think is related to the retinal activation, but and they'll also report like certain kinds of visions, in their peripheral field, and then of course loss of peripheral field where they can't see. And I don't know if we should put in the severe light sensitivity so many patients have, and in this sort of we're talking about the eyes, of course. So I think there's a significant
I think that's a really important one. Yeah.
yeah, I mean, the photosensitivity, I mean, is severe. I mean, we know that there's photosensitivity with migraines, but the level of photosensitivity in this patient population is way more severe than migraine
Yeah.
patients get with migraines.
Yeah, let's talk about the hypersensitivities because that's a for you and me and doctors who do what we do, that is the hypersensitivity to stimuli is a classic complaint of patients.
Mhm.
Often not just one stimuli, but it's, you know, 5, 10 times a week. Patients will say loud, no sound, light, fragrance. Okay. I react to and I can't stand it. And then and therefore these patients, a patient may come into the office or to the telemedicine wearing, headphones, earplugs under the headphones,
Mhm.
dark glasses. And now picture a physician who knows nothing about this. You
Right.
walk in looking like that. They've eye rolled before you even open your mouth.
That's so
They
true.
look at this person and they say, "Oh my God, what do I have here?"
That's so
Okay.
true.
So it's just such a huge issue. But the hypersensitivity to stimuli is huge, and it's complicated even more because it's sometimes patients can't tell you what stimuli it is, or they'll say, "I'm okay talking to you here in the office, but if we met in Starbucks where there's like other people talking, I lose it. I have no ability to focus at all." And again, that sounds kind of nuts to other people. Um, the fact that a patient may have the sun coming in the way it is now on me makes them brain fogged.
Hmm.
Makes no sense to most physicians. Okay, we hear it all the time, and it is very real. It's almost always related to either mast cell, again, cranial-cervical instability, probably not POTS so much, and I don't think we fully understand it, but it is the real of real symptoms.
Yeah, I
Don't
think
ever
it's
let it. If a
yeah.
doctor says you're nuts, that is absolutely
Not true. It's real. We hear
sayonara.
it all of the time. I mean, as we both have, I have some patients that come in, we have to turn off the lights
Right,
because they are so sensitive to light and any kind of stimuli. We have to talk at a low volume, if not outright whisper, which is obviously hard to have a full conversation, but definitely at a lower volume. We have to turn off the lights. We have to try to minimize the sound in the clinic. So yeah, so it's a real symptom and patients really suffer from it. And I do think it's related to a neuroinflammatory response. And I think that goes along with the mast cell activation. I think it goes along with the cranial cervical instability. I think it's just part of the post-infectious syndrome. I see it in a lot of long COVID patients, a lot of them.
and
And I will say that, I do ask about when they were young, a lot of, young children will have sensory integration disorders. And sometimes you get that history, but oftentimes you don't. So this is something new to them.
right.
They'll even describe, sort of an odd state of mind, or like an odd state of awareness. I mean, patients will just feel like they're dissociated. And they have a hard time even describing what that means. And over the years, I've sort of learned to sort of realize that they mean that they don't have a sense of connection with like their loved ones, like their family members. They
Right.
don't really have a sense of connection with where they are, who they are. I mean, they know who they are if you ask them outright, which is why, again, an eye-rolling symptom to other doctors, right? They know their name, they know where they live, they know who their spouse is,
Right.
and so on, but they don't feel that sense of connection. And that seems to go along with, excessive external stimuli. It just sort of seems to like delaminate them from their surroundings. And so
Right.
it's always been such an intriguing symptom to me, at least, just trying to figure out what that's about and what's the chicken and egg kind of thing, like how this started and where this is going kind of thing. So, but it's an interesting symptom, I think. And yeah, I find all these eye rolling symptoms to be interesting, to be honest.
Yes,
I always
yes.
feel
Well, I
like
think they give
just
us a lot of
flu.
information. I mean,
Yeah, they do. Exactly.
they help
Exactly.
me and you form a diagnosis. In this
Hmm.
case, it's never one diagnosis, but put it all together, which leads me to want to say this, especially for any physicians listening or healthcare people. Many, many, many patients will not volunteer these things. Okay. They're afraid to say them because they've already been eye rolled to hell. All right. Um, and it's an important thing to remember. I mean, it's in some ways it's obvious. You're supposed to take a history by asking questions, okay? But I can tell you, I take a 90-minute history, and towards the end, I have my sort of scenario is I'll say, all right, now tell me what the biggest problems you have in the last 2 weeks that are ruining your life, limiting your activity, making you miserable, et cetera, because I want to kind of hear it again. And I can't tell you how many times they'll give me the list, which includes everything we just talked about. And then they'll say, well, okay, do you have any problem with light or sound or fragrance? Oh my God. I
Yeah.
go into Nordstrom's and I'm ready to collapse on the floor. And over and over. So the point being, yes, we're supposed to ask the questions to get the history, but it's easy to forget that you really have to ask the questions.
Yeah.
Even
Yeah.
after 90 minutes of interviewing somebody, so many things might go unsaid. One, because they're embarrassed or afraid to say it. Two, because they don't realize it's not normal. A lot of
Right.
patients will say, well, yeah, I can't stand loud noise, but I thought that was normal, that people don't like
Right.
noise. Okay.
Right.
Yeah.
Exactly. Exactly. Who likes noise?
And
Yeah.
there's a lot of symptoms like that the physician or the healthcare person, whoever's seeing the patient, needs to work on asking questions for. And it's
Yes.
a reason to revisit the history over and over and over in the course of taking care of the patient. Did I miss something? I'm going to ask again.
Yes, exactly. And I think when I was sort of thinking about the conversation we were going to have today, I was thinking I should come up with a questionnaire of these eye rolling symptoms just so I don't miss asking them. So another one that I have found in long COVID patients specifically is where they tell me that they feel like their tongue is too big, but it's not, right? So they don't have macroglossia. You look at their tongue, it doesn't have the scalloping that is sort of the common finding when the tongue is too big for the mouth when it's swollen, but they feel like their tongue is too big. And when they're swallowing, when they're drinking water or they're eating a meal, they feel like they have difficulty time swallowing, which of course is dysphagia, but they specifically say they just feel like their tongue is too big in their mouth, which I think is an interesting symptom and might be related to a mast cell component, but I don't really know. Some, a lot of these symptoms I have to admit, I don't really know
Yep, yep,
what is behind it, but I'm intrigued by it and certainly am receptive at trying to figure it out,
right,
and working with other doctors who are willing to help me figure it out. But some things, like I said, I think are electrical in nature, but other things I don't really know. But I believe it because I
right.
hear it more than once, and I always say, like, well, obviously these patients aren't, there's no textbook that's describing these kinds of symptoms. So they're not reading the textbooks and coming to the doctor's office saying, oh, I have all of these things. So
Speaking
clearly
of
that's what they're experiencing.
and speaking of electrical, another one that I hear, which is a big eye roller, is vibration.
Oh, vibration.
Dr.
Yeah, no,
Catherine,
that's a
I
big
feel
one.
these
The internal
vibrations in
vibration,
my
the internal
body. I have
tremor. Yeah,
vibration.
yeah,
And if you're an employed physician with 15 minutes, forget it,
yeah,
vibration.
exactly.
It is so real. I can't see it, and the patient can't show me, but they feel these vibrations.
Mhm.
Um, and diagnostically, to me, it's often connected to, I hate to say it again, but a Bartonella infection. Maybe the other tick-borne infections, I'm less sure, but for sure Bartonella. I don't know the mechanism. I can make it up. I can tell you about what Bartonella does, and maybe that's causing vibrations. And the cousin of the vibration complaint is my muscles twitch.
Hmm.
But it's rare that you can see the twitching. The
Right.
patient's feeling it, right? So it's it's not a fasciculation, which is more visible, right? There's a bigger muscle groups, but they feel it, and it's very real. And that can be anything from a vitamin nutritional issue to mast cell activation to almost any of the stuff we talk about in septet.
Yeah, no, the internal vibration, the internal tremor is a very common one. And occasionally a patient will take my hand and like put it on their body and say, do you feel that? Oftentimes I don't. I will say that a couple of times I have. So I sort of get a sense of what they're feeling internally. You don't see it. There's nothing visual.
Right.
And they're usually their vitals are normal. Like, so of course you check their heart rate and their blood pressure and all that. And usually those are normal. But they feel like their bodies are shaking on the inside. And I think that's nervous system. I think that's neural tissue involvement. And what's triggering it, I do believe it's mast cell because I've treated it as a mast cell activation symptom, and there is often improvement, though not always, but often improvement. So I think it's an interesting one as well.
Right. So actually, what you just said made me think of something. So many of these symptoms um, signal mast cell activation syndrome kind of precisely because mast cell activation syndrome is one definition is a multi-system, multi-organ inflammatory illness that is occurring everywhere. And and that's why it's so hard for physicians not having not learned any of this to understand it or put it in any context. But if you think about it, mast cells are everywhere in our body. There's no mast cell sanctuary where there's no mast
Right.
cells. All right. And each mast cell has those 1,000 mediators and they explode and they release it. And that's bad enough locally, but those released mediators then circulate through your blood. So maybe you had a mast cell flare in your gut from food. Why would you get brain fog? Well, where do you think the mediators go? And so you
Right.
end up with this patient coming in saying, all of these eye rolling symptoms. You could have a whole choose from column A or column B menu of eye rolling symptoms, and they're all from mast cell activation.
Yeah,
And they get better. They
yeah,
get better.
they
You
get
treat the
better.
patient, they get
It's the
better.
nice part. Yeah, I mean,
Yeah,
a lot of these things do improve when you really manage those mast cells, which we say it like it's easy. It's not always that easy, right? It's
right,
not always just like we'll take some more famotidine.
right.
So yeah, sometimes you really have to work at managing those mast cells, but when you get them managed, a lot of these symptoms can certainly improve. And then speaking of which, so then the brain zaps and the electrical
Just
like
gonna do it.
sensations down the cord, you know.
Yeah,
So and I only smile because these are so common, and I smile because just recently, and I think this is what sort of led us to decide that we were going to do this episode. I said to you that I asked a patient, "Are you having any kind of brain zaps and electrical sensations down the cord?" And she said, "Yes. How did you know?" I mean, she was shocked that I asked that question and seemed so relieved that she wasn't crazy because it was clear that she was
right.
at least she told herself she was crazy, but at least I assume that other doctors had maybe said that to her. But um, so yes, that is a very common symptom, not only in long COVID, but ME/CFS.
Right.
So, and I also find it more common in the EDS patient population who have an ME/CFS kind of phenotype. And I'm not so sure if you've seen that as well, but
Yes.
that is electrical without question to me. And I think we often forget that the cord itself is neural tissue and it's physiologically and metabolically active. And so if there's any level of compression or impaired blood flow, you can have abnormal electrical activity, which can cause these electrical sensations. Interestingly, it seems to happen most commonly at night for patients. And I think that there's just a lot of symptoms are more, at least bothersome. I wouldn't say they're most common, but most bothersome to the patient later in the day or at night. And I think that because there's just, if we think about the rhythmic nature of some of the hormones, later at night is sort of when our bodies are meant to relax. And I think that that change in our autonomic nervous system, predominance of parasympathetic over sympathetic, allows these symptoms to sort of rear their ugly heads, where they're at least they're more noticeable to the patients, and then they become bothersome and can often interfere with sleep, of which, of course, these patients have a difficult time getting restorative sleep to begin with. So it sometimes can interfere in falling asleep and staying asleep and so on, because these symptoms seem to be present most commonly later in the day and early evening. And I think it's related to the autonomic nervous system change of
Right.
predominant activity. But those symptoms are very common. And brain zaps, I think, are a CCI symptom until proven otherwise.
So also related to brain zaps, since and it's interesting. A lot of what we're talking about is neurologic. Partly, I think, because it's harder to see for the physician, so it makes it even more
Right.
susceptible to eye rolling. So
Right.
related to the zaps, how frequently, Eileen, do you hear a patient say, literally, I feel like my brain is on fire,
Yeah.
or I feel like I can feel my brain. Okay. Well, every physician you meet is going to tell you you can't feel your brain. There's no
Right.
such thing as
Right.
feeling brain pain. And yet patients feel it
Yeah.
and they describe it and they talk about it and they can tell you what causes it. They can tell you the trigger. They
Hmm.
can say, I walked into this part of the house and my brain just feels on fire. Right. And and again, if you reject the symptom, if you eye roll at it, you'll never get anywhere helping that patient. And conversely, if you think about it and try to put it in the context of everything else, that means something. So Brain on Fire could be sort of the classic book by that title of autoimmune encephalopathy or NM,
NMDA.
NMDA receptor autoantibody disease. But it can also be, quote, brain fog. It can be from leaky gut. It can be from SIBO. Certainly can be from mast cell. It can be from something as simple as you're not getting enough blood to your brain because you have POTS.
That's
And every
right.
time
Oh
you
yeah.
stand
No,
up, your brain is
absolutely.
on
POTS
fire.
is a major driver
Yeah,
of a lot
exactly.
of it. Yeah.
So again, it's this the symptom is what the patient feels and what they report. And the fact is, or the truth is, the sad truth is, we don't always have the words to report as what we're feeling in a language that makes sense to the listener.
Clinically, right. Absolutely. That is a really important point. And that is something that I would often say when I worked at the children's hospital. It was clear to me that kids don't have the vocabulary to really describe what they're feeling. And so oftentimes, it wasn't understood by doctors, by even parents. And so you have to sort of learn their language. And it's similar to the chronic illness patient population. They sort of learn a language on their own. And the way they describe things, and sometimes they'll actually grab on to more classic words and classic definitions. Like, as we know, a lot of patients will go to an ER and say they had a seizure, right? And it's it's seizure-like for sure, but the only way they know how to describe it was this was like a seizure event because they had
Right.
lots of time. They might have been witnessed to have abnormal movements by their partner, by a family member, by a friend, by a colleague. So they're taken to the ER, but workup is negative, including EEGs, and the description is often that I've had several patients with this kind of description where they report not loss of consciousness, like they were aware of their surroundings. They heard people talking around them, but they were not responsive and they're convinced they were having a seizure. But, classic teaching of generalized seizures, I should say, is sort of loss of consciousness, and you can't be non-responsive, but be aware of your surroundings kind of
Right.
thing. So they have these seizure-like events, and I will say that that is and they're just as you know they're given a diagnosis of pseudo seizures or functional neurologic disorders, and but they are really truly having paroxysmal neurologic events, and that's what I put in my note. And I think that class of that I think that label is an important label because in neurology, there are a lot of paroxysmal events and there's a lot of paroxysmal neurologic symptoms. I mean, even migraines are paroxysmal, right? So for most patients, obviously there's something called status migrainosus, as there is status epilepticus. So yes, you can have something going on that's chronic and consistent that's not paroxysmal, but more commonly it's paroxysmal. And so the fact that there are these recurrent episodic neuro events, they're not seizures, which are an electrical aberration, and there's a very specific definition of them, but they are seizure-like, frankly. And patients have these things all of the time, and they are constantly being told these are pseudo seizures, these are, you know, functional seizures, and I think that does such a disservice to the patient and to the symptoms that they're experiencing. And that's problematic. That's problematic for the
Well,
patient,
it's
problematic
problematic,
for
also,
us. Yeah,
also problematic because it enters the chart in the hospital
right. And
system,
it
which is
stays
Epic.
forevermore.
And now you have from San Francisco to New York and every hospital in between, you walk in the door and they open up Epic. Patient has a history of pseudo seizures and functional disorder.
Right,
Bam. You don't even,
right.
it's past eye rolling. They don't even open their eyes. They just keep the lids down.
That's right. And speaking of
So,
functional disorders, I mean, a lot of our patients will say that they have abnormal, like gait kind of thing, so that they don't feel steady, that they feel off balance, and then obviously on exam, the classic exam findings are not there. And so, in the functional neurologic disorder world, there are a lot of movement disorders that are considered dysfunctional and not real. And I know that there are ways, that they sort of train neurologists to sort of look out for those, things like when you walk, if every time you sort of seem to fall, if you catch yourself on the wall but never actually fall down, they consider that functional because you shouldn't be able to control when and how you fall, kind of thing, if you truly were off balance. So there's a lot of gait disorders and a lot of movement disorders that are put into that class of functional disorders.
and let's connect, Eileen, let's connect what you're saying to probably the most common finding in our complex patients, which is POTS and dysautonomia. So um, what you just described is a classic POTS hypoperfusion symptom.
Mhm.
Patient doesn't, they feel, they've learned, uh-oh, I'm getting, something's wrong, I
Right.
might faint, okay? They might not say that, but that's what they're realizing. And they will lean over to the wall, okay? So it is actually I don't want to say life-saving, but it's a preventive maneuver that they learn to do based on what they've learned about their hemodynamic disorder, which is called POTS. Similarly, patients will come in or go to their doctor or whatever and say, I don't know, whenever I stand, my body just feels so heavy. My legs are heavy, like I
Yeah,
have a lead weights on my legs, or like I have lead on my shoulders. And again, that's an eye rolling for those doctors, but that's almost as classic as you can get for POTS,
right.
orthostatic intolerance. Patients are not going to come into their doctor and say, every time I stand up, I feel my blood pressure drops, my heart rate spikes, and I know I'm not getting enough blood. They're not going to say that. They're going to say what they feel, which is what
Right.
they're supposed to do. And in fact, one of my side diversion, okay, one of my issues sometimes with patients is when they tell me I have POTS and therefore this is what's happening. And I say, look, I actually don't want you to give me your diagnosis. I want you to tell me what you feel.
Yeah.
Because number one, they might be wrong. And what they're attributing the symptom to as POTS might actually be brainstem compression. I want to hear the symptoms. So
Yeah.
I think it's annoying to the patient, although nobody's ever called me out on it. But there's a reason I do it, and I think Eileen probably does it too. It's the symptoms and how you describe them that help educate us to figure out what's wrong with you.
Yes.
And okay.
Yeah. In fact, I very regularly say to patients, they'll say something like, I'm trying to come up with an example. Um, like they'll say, yeah, they'll just like what your example, I mean, that their legs feel heavy. Or I'm trying to think of a better example. What I regularly say to them, tell me what that means to you. Like, what is that? Tell me more about that. I
Right.
commonly say that because I like to hear patients describe what they're feeling. And I agree with you. It's nice to know they've been given a diagnosis of POTS and small fiber neuropathy and MCAS and all that. And I often will ask, well, who made the diagnosis and on
Right.
what basis did they make it? And what symptoms did they associate with that diagnosis? So I
It's
try to get that kind of
yeah.
information.
It's an interesting, almost like a backfiring. So the one that I hear this most often, the situation where I think I hear it most often is the patient has either learned online from friends and whoever, or from a physician, oh, you must have mast cell activation syndrome. And now, even though I 5 minutes ago said how many symptoms can be caused by MCAS, from top to bottom, now the patient attributes everything to MCAS. So they'll say, every time I stand up, I get brain fog. It must be my mast cell.
Mhm.
And that's not correct
Right.
necessarily. And if we can't separate out their diagnosis from their symptoms, you and I, Dr. Ruhoy, Dr. Kaufman, whatever, we're going to miss things. We're not going
Yeah,
to
for
pick up what we
sure.
need to hear.
For sure. And that has happened like earlier in my career. I just sort of went like, oh, I know those doctors. I recognize those names. If they gave you that diagnosis of POTS and said that the symptom was attributed to that, then that must be true. And so I just sort of went on my merry way with them. But over the years, I've learned that no, sometimes there's a symptom that's not in that POTS box, or not in the small fiber neuropathy box. And so there's another reason for it, which just only means that there could potentially be a different treatment for it to help it, right? So I think that that's why we spend so much time with patients is that we really try to get to the core root and the problem of what is underlying a particular symptom instead of just saying, oh yeah, that's clearly related to your MCAS, you
Right.
know. So, and I think that's important because the other thing is that, years ago we didn't know these diagnoses as well as we know them now, and who knows what else there is out there.
Yeah,
Right. So
exactly.
I
Exactly.
I like to feel like we don't know everything yet. Um, Another thing is the air hunger kind of feeling, right? Where all the oxygen, pulse ox is normal and, their PFTs are normal. And, sometimes even they go as far as someone ordered a VQ scan because they had, these patients regularly have elevated dimers, right? And then they report this air hunger. So I think a lot of doctors, of course, to be safe and make sure the patient is safe, will order, chest scans throughout pulmonary embolism, and there are none. But they still have this air hunger that they report, which I always find to be interesting, sort of what's behind that. I always think of it as I used to think of it a lot as a mast cell kind of concern because sometimes you give things like Montelukast and it does seem to help, or, you put them on oxygen and it does seem to help. I've sort of come to realize that I think it's part of like the mitochondrial issue, because those respiratory muscles are just sort of
Yeah.
struggling with it.
I think for sure it can be mitochondrial or it is, but I also think it occurs. I see it with POTS.
Hmm.
Again, I want to emphasize something you and I have said over and over and over. POTS is not just I get dizzy when I stand. Okay, it is not just I get lightheaded. And I over and over patients will describe their shortness of breath, and if you dive into that rather than eye roll, you dive into it and ask, when do you feel that? Why do you feel it? What are the triggers? It becomes pretty clear it's related to hypoperfusion and
Hmm.
POTS. And
Yeah.
I'm using POTS in a very loose way. I'm just
Right.
saying there's a hemodynamic issue when you stand. Excuse me. Um,
See some water.
just one second. There was something else I was going to say.
Sorry.
That's all right. Oh, shortness of breath, air hunger. So another cause for air hunger besides POTS is infection. Babesia, one of the tick-borne infections,
Oh,
is sort
interesting.
of notorious for causing this feeling of air hunger. And it will get better when you treat the patient.
Interesting.
First time
I
I
didn't
heard that,
realize
I thought,
that.
oh,
Yeah.
first time I heard of that, I rolled my eyes from a physician telling
Yeah.
me this. I just,
Right.
come
No,
on,
that.
what are you talking about? But then you think it through, you think through the pathophysiology of the organism, what
Yeah.
it does, it latches, it nests on red blood cells and things like that, and suddenly you can kind of understand it.
No, and
Another
I
cause,
that's yeah. Go ahead. Sorry. No, I want to know what more what you
so
do.
another air hunger, particularly in long COVID and probably in ME, but I think we see it more in long COVID, is this whole microclot issue,
Mhm.
right? The idea is not pulmonary emboli, which is a big clot. Okay, we're talking about little stuff that clogs up the capillaries, makes the blood sludgy and sticky and slow, and that screws up oxygen transfer in the lungs and perfusion, and you get this feeling of I can't get enough breath. Or they say, I can't take a deep breath. It's just something stops me from fully
Yeah.
inhaling.
Yeah, no, that is so I think that you bring up a really important point. And you're right. I was thinking about the hypoperfusion that you had said earlier, and that I do think plays a very important role in two ways, but you just sort of added the third way. The microclot, I think, is a very important piece of information that we've learned from the long COVID research that I think definitely applies to ME/CFS as well, specifically with these kinds of symptoms. But um, the other thing is that so when there's hypoperfusion, of course, then the mitochondria don't get their oxygen, and so they can't really perform oxidative phosphorylation, and
You
they
mean
start.
everything's connected?
Yes, it's magical. But also, those compression syndromes. And so it's like all the vasculature in our bodies, it's like the highways and byways, right? They all connect somewhere and somehow.
Right.
And so I often think if there's compression anywhere, eventually there'll be slowing of blood everywhere. And then there'll be some hypoperfusion, right? Because there isn't enough force to perfuse the oxygen molecules through into the tissue. And so when we're finding all these compression syndromes, specifically in EDS patients, and I think again, as the blood sort of is flowing and then gets to a narrow, vessel, it has to slow down. And then over time, that slowed velocity will just back up. And it can take a very long time until it's there. It affects other parts of the body, of course, but I do think that it's playing a role because if somewhere in the body there isn't appropriate blood flow, I think that there's upstream and downstream effects eventually.
Well,
And these
that
patients, of course, have been chronically ill, so it's not like they're just presenting on day one of this
right,
compression,
right.
right?
And
So
that,
I
that
worry about how
this
much that's playing a role.
yeah. The slow velocity also is somewhat self-perpetuating
Mhm.
because every time every time there's turmoil, physical turmoil in the blood in the vasculature, and every time the force of blood slows down, there's an increased risk of more microclotting, not
Yes,
necessarily from long COVID. That's actually just a physiological event that can happen to
right.
anyone. So
Stagnation.
it is more begets more. You get more and more of this problem, and then the person gets worse and worse. And if you don't recognize this possibility, all the drugs in the world don't fix the problem. You
That's
know,
that's
and
exactly right.
it's I think for me this is a little bit off eye rolling for a second, but for me that's been um, a huge educational moment was learning and hearing about it and learning and thinking and then studying the whole role of venous compression syndromes in the abdomen and pelvis. In all these patients where I throw drug after drug after drug and they don't get
Yeah,
better, their POTS doesn't get better. Stupid, of course, it doesn't get better because they're not getting enough blood to their heart because they have compression in their belly. And
that's
I
exactly
fully
right.
confess, I didn't know that. I didn't
No,
think
and it's
about that
funny because I
before.
think I think back on like the early days of when I was even learning about hypovolemic POTS. I've read some amazing article that I honestly wish I could find because I would love to give credit to the authors, but they talked about how the blood pools in the mesenteric splanchnic bed. And I would tell patients that that's why abdominal binders can be so much more effective than the leg stockings and the compression socks, because that's where the blood is pooling. And so the blood from the legs it gets stuck. It just can't get back up to the heart. So the preload is lower, but it's stuck in the splanchnic mesenteric bed. And the fact that I didn't then relate it to pelvic venous congestion
Right.
just sort of bothers me.
Yeah, same with me, by the way. I
Yeah,
mean, I knew about the small bowel area and where the
right,
blood pools, especially after you eat and everything.
right,
I just
absolutely.
didn't know about the other.
Yeah, no, me neither. I know, and it was that
It's eye-opening. It's
yeah,
incredible.
it is eye-opening. And then once you learn it, I always say once you see it, you can't unsee it.
Right.
But so now it's like it's one of the things on my list that I sort of go through when I'm thinking about
Yeah.
every individual patient. But speaking of eye rolling, speaking of compression syndromes and eye rolling symptoms, I mean CCI is still people still eye roll at that.
Oh, yeah, I guess we should include that. And tethered cord, let
And
alone
tethered cord, I know.
a cult tethered cord.
A
Talk
cult
about
tether cord.
really
I
making it
know that is
mysterious and
really
eye-rolling.
eye-rolling.
Oh, I have hidden tethered cord.
Or even retethering, people, a lot of surgeons
Right.
I mean, I've had a lot of patients who they go to different surgeons who say that, I mean, some are just frank and say CCI doesn't exist or
Oh, yeah.
cult tethered cord doesn't,
The
that kind of.
whole countries say that, not just
Right. Well, I
doctors.
mean, some will entertain the diagnosis, but are really against like the fusion surgery to correct it. And some will say it might exist, but it doesn't contribute to the symptoms you're describing, kind of thing. So I think there's a spectrum of eye rolling to the
Right.
CCI diagnosis, but we've seen obviously, incredible improvement from just addressing the classic CCI that we prove is contributory to the pathology of the patient just by the invasive cervical traction, which we've talked about. And we should actually do another episode on that. But yeah, so we know that CCI exists and we know that it can contribute to the symptoms. It doesn't always, again, which is what the purpose of the ICT is. But there's a lot of eye rolling out there about
Right.
CCI
For tethered cord too. I mean,
and
in
for
some
tether.
ways, I think tethered cord is even more mysterious to most physicians. It's
Yeah, yeah. I think because I think the imaging is a little bit less it's like I think with the CCI there are measurements to be done, and
right,
that's at least a topic of conversation to be had amongst those who are, working with patients like our patients. But tethered cord, I think it's even challenging for me on imaging to sort of recognize it.
right,
So, but I also recognize the symptoms, and I know that sometimes there's no other explanation for this constellation of symptoms other than a tethered cord, especially when there's abnormal urodynamics in an EDS patient, with the classic leg pain and feet pain and urine and bladder concerns. So but the imaging can be difficult, and I think that's where it goes wrong and why a lot of doctors are just eye rolling at tethered cord
right.
diagnoses. So, but those are very, very common. Anything else on your list?
I'm trying to think of some more. We didn't do much on GI, but GI often is
Yeah, I guess a
is
lot of eye
is
rolling.
less eye roll. Well, it gets eye rolling, but the symptoms actually most physicians will relate to. I mean, excuse me, if a patient says I get gas and bloating, or every time I eat something happens, that will click off some action on most physicians.
Yeah,
They
for
might
most.
not
But if it's
get
a
that
normal
it's
workup, as you know, then they just start eye rolling. A lot
right.
of doctors don't sort of embrace the whole SIBO, SIFO, gut kinds of concerns. You know, Constipation is just constipation, and they'll
Right,
prescribe a lot of medications, and
right,
um, so I mean, as we've learned, because we even interviewed Dr. Anstead, who, was given a diagnosis of colonic inertia and had her colon resected, right? So,
right,
I mean, so I think that's eye rolling because it means that the doctors aren't like thinking about and listening to the patient enough and taking it seriously enough to go do a further workup and just deciding we need to just remove your colon. That's the answer.
yeah,
So, and so I do think that there's a lot of eye rolling and, for a lot of GI symptoms that our patients suffer with, which is very, very common, very
right.
common.
I think we probably should put in the symptoms that patients complain of when they have a peripheral neuropathy in terms of pain and numbness and stuff like that. Partly because for many physicians, they can't see that, they can't
Right,
diagnose it, so it does begin to sound eye rolling.
right.
And it's a particularly frustrating one because it's a miserable, miserable
Oh, yeah, for
illness to
sure.
have, which we're not very good at fixing when we do recognize it. And it's very common. I mean, yes, it's common in the mainstream world in diabetic patients and in certain vascular disorders,
Yeah.
but it's usually common in our patients, with or without
Very,
um,
very, very common. Very common.
microscopic small fiber neuropathy. It's a
Yeah.
big, big complaint. And unfortunately, a lot of healthcare people, if they can't label it, then they just stop believing it. If they
Right.
can't put a name to it, I don't know what's wrong.
Right. Or they'll try the common low-hanging primary line treatment. And if the
Right,
patients don't respond, I mean, not that they won't try a second, medication maybe. But at some point they just sort of give up if it's a refractory kind of symptom, they just sort of give up and really just say that they have nothing more to offer or nothing more to do. But I just sort of see it as the overall picture. And I think that that's what's important. And what I think we like to impress upon other doctors, because we want to recruit doctors into this space is that you can't look at these symptoms as an individual symptom that is just not responsive to like gabapentin or
right,
pregabalin.
right.
You have to sort of look at it as the constellation of a whole,
Eh,
and not to sound sound functional medicine like, but it really is like it's an entire body problem, right?
Right,
And this is how it manifests in an individual patient. It might have these individual symptoms that sound a
right.
little like, what's that about? But it really is happening to these
I,
patients.
I think it's good to sound functional medicine like. I mean, I would argue that's
I don't
what
want to, I
internal
mean, I never did the
medicine
training, so I don't
was.
want to pretend like I know.
That, but that's what internal medicine used to be,
Right.
total body stuff. Okay.
Yeah.
Um, I don't want to end without discussing one of the 800-pound gorilla symptoms that are really eye rolling, and that's post-exertional malaise, PEM,
Mm.
post-exertional malaise. Okay. That is the defining, literally the defining characteristic of ME/CFS and now long COVID. There's been a whole bunch of articles, papers recently coming out confirming over and over and over how PEM is the keystone or the foundation for these illnesses, and we still don't fully understand it, but we're beginning to home in on it. But
Yeah.
you can't see PEM. You
No.
can't really describe it to most physicians or to your partner or your family or your friends. It's it is confounding. I mean, to say if I walk my dog, I have to lie down for 2 hours or worse. If I walk my dog the next day, I got to lie down for 6 hours. People are not only going to eye roll you, they're going to just think you're nuts. Okay.
Hmm.
You're not nuts. It is a foundational diagnosis. And
It really,
if you think you have PEM, find a long COVID doctor or a complex illness doctor, an ME/CFS doctor. I almost want to say, don't waste your time on your initial regular primary care doctor, although maybe they'll be more open-minded now because of the literature.
hmm.
Um, and I want to also expand on something you said, Eileen, about other doctors. Okay. I know that I sometimes, or maybe even often, sound negative, and I don't really feel negative about them. I feel sympathetic because of the
Oh yeah,
work
so do I.
system and context they work in.
Yeah.
But what I would say to those that are listening, or if anyone listens, once you
If anyone
stop
is
eye
listening to
roll,
us.
once you stop eye rolling, and once you begin to read about or think about or learn about the septad, or if you don't want to use that term, about POTS and mast cell and venous compression and May-Thurner syndrome, your world just opens up. It is so incredibly intellectually exciting and so different from seeing sore throat after sore throat after
Yeah.
sore throat or hypertension checks over and over and over. I just want to emphasize that to those healthcare people out there. I mean, except when I did early HIV medicine, this is the most exciting kind of work I've ever done. It's just
I
amazing.
completely agree. It made me love medicine again and love neurology even more,
Right.
frankly. And and what's sad to me is that sometimes I feel like my world has gotten bigger, but I see patients whose world has gotten smaller. And that's the key. And so I want to use, I want to apply what I'm learning and what I believe and what I'm seeing to help patients expand their world, right? Because that PEM, of course, as we know, these patients have to, some of them who are really severe, I mean, they have to go into a dark room with, as you described,
Yeah,
with
yeah,
shades on and the earplugs and the headphones, and they have to whisper. They can barely go to the bathroom without crashing. Even conversations can cause a crash. I mean, some of them are really severe where their lives are just very, very tiny now. And they had big lives before they got sick, right? So
yeah,
that's what's
yeah.
heartbreaking about this. And you and I both get emails, just, from patients like just long emails with pictures of like what's happened to their lives, and it's just heartbreaking. And so, that's the kind of work that we love to do is try to help these patients back to the life that they had had before they had gotten sick. But, we want other doctors to sort of join us and we're willing to train and teach and educate, hence us doing these podcasts for the last 2 years. 2 years have passed. Can you believe it? But so yeah, I agree with you. It makes medicine that much more exciting again because we're thinking again, you know.
Well, and we're really on the cutting clinical edge of medicine,
Yeah, we are.
unfortunately, long COVID has really driven that home. Finally, mainstream NIH type medicine is recognizing that, but there's still such a disconnect between their work and the academic research and the clinicians, and they still haven't. None of us have figured out a way to join effectively, and that's just very discouraging. That said, to be on the clinical cutting edge for a physician, or for me, for this physician anyhow, is just so exciting. And that
Yeah,
was true in the HIV era, even though it was so sad and depressing and tearful over and over and over. as a physician intellectually, it was incredible.
Hmm.
And I feel like reborn doing this stuff. It's
You
amazing.
are. You are reborn and you're teaching lots of, including me. You've taught me quite a bit.
Well, and same with
So,
me,
well, it's like a mutual admiration
right?
society.
So
All right.
I think we'll finish up. If we missed any eye-rolling symptoms, send
I'm
them
sure we
in. Make a
did. Yeah, I
list.
mean,
Make a list. Seriously,
yeah.
people watching, patients who have these problems, give us a list. What? Oh,
Yeah,
you didn't
we
talk
will. Yeah,
about
we'll
this. You
talk
didn't
about
talk
them.
about that. And again, please subscribe. Please send out the
Yeah, tell
word.
everyone to subscribe and I'm going to post this on Blue Sky and maybe even Twitter or it's X now. I don't know why we still say Twitter, but it's X. But I know you're against X.
Okay.
But
I got to draw
we
some
we want
lines in the
subscribers.
sand
I mean, we
still.
have our I think, we have to just remember we have our own mission and it's politically neutral, right? So like I just want to make sure that we, continue our good work in this world and leave an impact for all patients and hopefully that, the new administration will be at least this, it will at least will be better for patients that we see. I don't know. I don't know why I said that, but
One can hope.
fingers crossed.
Look, if Syria can change, maybe we can change.
Exactly. Right. I'm always hopeful. I'm always optimistic.
Right.
And that's how I stay alive.
Okay. Well, thank you all. Thank
Thank you
you.
for listening. We will see you soon.